This is my last lecture in my series on nausea and vomiting, and I wanted to end up addressing the topic of antiemetics. My purpose is not to give a long laundry list of drugs used, but rather to go over the basic categories, and then I'll give an example or two of a drug in each of the categories. The first one I want to talk about would be serotonin antagonist. We saw earlier that the 5-HT3 receptor, which is a serotonin receptor, there are many types of serotonin receptors, but the subtype 3 is the one we want to talk about. That is the one that seems to be playing a role in nausea and vomiting. So if we're talking about a serotonin antagonist to the 5-HT3 receptor, I think we have an understanding of what an antagonist is. So an antagonistic or an antagonist molecule is going to bind to the receptor but not have the normal biological effect that a normal molecule would have binding to the receptor. So in other words, when serotonin binds to a serotonin receptor, it has its biological effect. But if I have a molecule that we consider to be an antagonist to that receptor, when it binds to the receptor, you don't have the normal biological effect as would if serotonin were to bind to it. So it blocks the activity of serotonin. So any type of molecule that falls into this category is going to work wherever the 5-HT3 receptor is. And so we found out earlier that it is in the central trigger zone, which is, of course, the area postrema. And we find that in the medulla. It is also the 5-HT3 receptors found throughout the peripheral system. So giving somebody a drug in this category is going to work both centrally, central nervous system, and in the periphery. And in particular with this one, we're mostly talking about the GI tract. Because you will recall that this receptor, the 5-HT3 receptor, is very important in the GI tract in that we have the vagus nerve innervating the GI tract, or most of the GI tract, and you have a strong sensory component of the vagus nerve, so it's sensing what's going on in your GI tract. And in the case of nausea and vomiting, any type of irritant or stimulant having to do with GI that is going to upregulate or increase the level of serotonin, then that serotonin binds to the 5-HT3 receptor. At the sensory end of the vagus nerve, that will increase action potentials going up the vagus nerve, which will then release neurotransmitters to the nucleus tractus solitarius. And part of the nucleus tractus solitarius, of course, as we saw earlier, is involved in the vomit center. And then when that axis is stimulated, of course, the end result is nausea and vomiting. These types of drugs commonly used for people coming out of post-operation. As we saw earlier, some types of anesthetics can cause nausea and vomiting. Can be useful in post-radiation sessions where someone is dealing with cancer and radiation is part of what they're having to deal with. Of course, as we saw, the radiation can cause nausea and vomiting, so this would be helpful for that as well. And also for post-chemotherapy, particularly the acute phase. So we remember we have chemotherapy-induced nausea, vomiting. It is broken into two categories, acute and delayed. Acute means the response of nausea and vomiting when you're having chemotherapy at the moment or shortly afterwards. The delayed type of nausea and vomiting in response to chemotherapy occurs 36 to 48 hours later. Evidence shows that those two seem to be different mechanisms. The instantaneous or the type of nausea and vomiting you have during and closely after the chemotherapy session, that is thought to involve the serotonin axis, whereas the delayed is thought to be more involved with the NK1 substance P. So if you're wanting to treat both of the nausea, vomiting, delayed, and acute, you are probably going to be using two different drugs for that. Then we'll talk about that a little bit later. Interestingly enough, ginger has some 5-HT3 antagonistic activity, and so it's kind of a home remedy. Some people who are struggling with nausea and vomiting, if they take some ginger, that seems to help for some. Ondansetron is a common drug that falls into this category of serotonin antagonist. So it's going to be binding to the 5-HT3 receptor, blocking the activity of serotonin. There are other drugs with other names that have the same mechanism, but they're easily recognized because they're going to have the citron at the end of their name. Another category would be anticholinergics, more specifically anti-muscarinic type of drugs. Acetylcholine, which is a common neurotransmitter, binds to muscarinic type 1 receptors. We'll call those M1s. And we saw that those are found in the vestibular nuclei. Of course, the vestibular nuclei are found in the medulla and the pons of the brainstem, and also found and associated with the vomit center in the medulla as well. And you would guess that when we're talking about nausea and vomiting having to do with motion sickness, the vestibular system is involved, so it would not surprise you that drugs that fall in this category are fairly effective in nausea, vomiting issues associated with motion sickness. So a common drug for that, one would use a scopolamine patch. I'm sure you probably have maybe even used it. It's a patch, it's transdermal, so you're going to put the patch on, and then the chemical or the drug goes through the skin and works on antagonizing that M1 receptor and does a lot in terms of abating or attenuating motion sickness, nausea, and vomiting from motion sickness. A third category would be antihistamines. In particular, we're talking about the H1 receptor. So a drug that is antagonistic to the H1 receptor would work, again, wherever the H1 receptors are found. So we're talking about the vomit center, central trigger zone, and vestibular system. And like the anticholinergics or the antimuscarinics, if we're talking vestibular system, then it's a pretty good bet that it's going to be helpful or effective in dealing with motion sickness as well. And so that's, in fact, how it is used. So the diphenhydramine, which we know is Benadryl, and the dimenhydrinate, which is Dramamine, both of these are antihistamines. When you take them, they dry you out. But these can be very effective for tapping down nausea, vomiting associated with motion sickness. Our fourth category is neurokinin-1 antagonist, and we'll call these NK1 receptors. These tend to be a newer class of drugs. These are antagonistic to the NK1 receptor, and you find those, of course, in the vomit center in the central trigger zone, and also you find them in the peripheral system as well. And as we talked about earlier, the neurotransmitter that binds to the NK1 is going to be substance P. These tend to be effective, or these class of drugs tend to be effective for post-operation nausea and vomiting, and also post-chemotherapy. And again, as we said earlier, in particular, the delayed chemotherapy-induced nausea and vomiting. Aprepitant is a common drug for that. And there are other drugs that fall in this category. And again, you can look at the end of the name, and they'll all have the pitant associated with the name. So if you look at the pitant, look for the pitant, and then whatever comes before that is going to fall in this NK1 antagonistic category. Typically, particularly if you're talking patients that are struggling through chemotherapy with nausea, vomiting, you're going to have multiple approach. So you would give these patients a cocktail of antiemetic, anti-nausea medications. Sometimes if one doesn't work, you'll pair them with others to have a greater effect for these, and particularly with the chemotherapy, with the delayed and the acute, you certainly would want to be utilizing both of those. Next category would be dopamine antagonist, and we're particularly talking about the D2 receptor. So this class of drugs is going to work on the central trigger zone and the GI tract. These drugs that work on the D2 receptor also have a prokinetic activity. Prokinetic activity means you give the drug and it's going to increase GI gut motility. Many of these drugs not only interact with the D2 receptor, but they also cross-react with the 5-HT3 as well, so actually inhibiting both, which can make them a powerful antiemetic, anti-nausea drug. Let me make a historical point here, which is that these drugs are also considered some of these drugs are considered antipsychotics or neuroleptics. Haloperidol would be kind of a famous one. For someone who has psychosis or other type of psychiatric activity or psychiatric challenges, neuroleptics or drugs like them would be given and seems to be reasonably effective. These drugs also can help with nausea and vomiting. There are better drugs out there now for that, so this is not a go-to drug for someone struggling with nausea and vomiting, but historically, in the past, they were used for that. The major downside for the neuroleptics is they tend to cause tardive dyskinesia. You can look at the word and tell what it really means. Kinesia, movement, bad, so dyskinesia, bad movement. Tardive simply means delayed, as in something being tardy. So typically what will happen is you put somebody on this class of drug, and then many months afterwards, even if you've just finished the drug or if they've been on the drug for a long period of time, several months afterwards they'll start developing motor problems, movement disorders, etc. So that's the tardy part of that. And once those movement disorders begin, it's a little tough to actually address that. So it's a real downside using these drugs. So this is why you would not want to really go for these drugs if you're dealing with long-term nausea and vomiting. There are better drugs out there. Metoclopramide is a drug that is a D2 antagonist. This typically is, you give this type of drug for patients who are struggling with Parkinson's disease. Now, what's the connection with this and Parkinson's? Well, as you may know, someone who is struggling with Parkinson's disease, the reason that they have Parkinson's disease is because there are certain dopaminergic neurons that synthesize and release dopamine as a neurotransmitter. Those neurons begin to die in the Parkinson's patient. So the central nervous system has an abnormally low amount of dopamine. And it is thought that that low amount of dopamine is causing the classic movement disorders associated with Parkinson's. Now, in particular, those neurons that are closely associated with Parkinson's symptoms is going to be the dopaminergic neurons in the substantia nigra of the midbrain. And there's a little part of the substantia nigra called the pars compacta. That's where those dopamine neurons are. They begin to die, and the result is classic Parkinson's symptoms. So the strategy in helping people with Parkinson's in terms of their symptoms is to try to replace the dopamine that is lost because those neurons die. So one strategy is to give them levodopa or L-dopa, and L-dopa can cross the blood-brain barrier. Interestingly enough, dopamine cannot cross the blood-brain barrier, so given a patient dopamine, the dopamine is not going to make it into the central nervous system. But L-dopa will. So if you give a patient levodopa or L-dopa, that can cross the blood-brain barrier, and then the central nervous system will convert the levodopa into dopamine, and you get your effect. The problem, though, is that when the L-dopa is administered and it gets converted to dopamine, it starts to interact with that D2 receptor, causing nausea and vomiting. So that's a common side effect for people who are struggling with Parkinson's. They're coming in, they take a drug to help them with the movement challenges, but then the drug itself causes them to become nauseated and a lot of vomiting. So this drug has been particularly helpful. This class of drugs have been particularly helpful in binding to the D2 receptor and kind of pushing back on that nausea, vomiting result of taking levodopa. And many people find that very effective. Also, this class of drug seems to also be effective in terms of nausea, vomiting with post-operation. Seems to be fairly effective with people who have nausea and vomiting associated with migraines. And of course, post-radiation and post-chemotherapy. The sixth category are cannabinoids. And here we're talking about CB1 receptors, cannabinoid type 1 receptors. There are others. The CB1 receptors binds to endocannabinoids or endogenous cannabinoids. The interaction of these endogenous cannabinoids binding to the CB1 receptor, not fully understood, but they seem to play a role. They're found throughout the body. They seem to play a role in memory, in mood, in pain, in appetite. Again, a lot of work to be done on this, but they seem to be involved in these processes. So when we think cannabinoid, typically we think marijuana. There are a lot of bioactive molecules associated with marijuana, of course. But the two major bioactive molecules is going to be the tetrahydrocannabinol, and that is going to be THC. And that's the psychoactive molecule. That's the molecule that gives you the buzz or the high when you smoke marijuana. The other is cannabidiol. We're going to call that CBD. And that has less of a psychoactive effect. But both of these molecules, again, are just considered cannabinoids. The receptor interaction of these two molecules is rather interesting. The THC and the CBD, they're agonists to the CB1 receptor, but not in the same degree. Now, you'll recall that the CB1 receptor, you find those in the vomit centers, and you'll also find them in the GI tract. But the difference is that the THC has a very strong affinity for the CB1 receptor, and that is where it is thought that its therapeutic effect is mediated through interacting with that receptor, whereas the CBD's affinity for the CB1 receptor is rather weak. The thinking on that is that the CBD also seems to influence serotonin function as well. And so the thinking is if there's a type of antiemetic, anti-vomiting result from the CBD, it may be through the 5-HT as well. Also, there's some evidence that the THC can also interact with that 5-HT3 receptor. So again, much to be worked out on this, but the bottom line is that it is shown that these types of molecules can be effective in anti-nausea, anti-emesis. Now, I want to give a word of caution on this because the smoking marijuana itself, interestingly enough, has a kind of a paradoxical effect compared to what we're talking about here, because smoking a lot of marijuana can cause vomiting. So the research seems to suggest that if you are taking in marijuana, at low doses, it seems to be helpful in terms of anti-nausea, but at higher doses, it seems to promote emesis. So dosing tends to be critical at this point. So simply smoking marijuana is probably not the best approach in terms of having or getting this drug in you to have the therapeutic effect that you would want to have. So there is a synthetic THC, dronabinol, and that is an antiemetic, anti-nausea. It is also used as an appetite stimulant for someone who is losing a lot of weight and they want to increase the appetite. This is one of the things it can be used for. But this is can be effective, and so and the reason that this is preferable is because smoking marijuana, you have so many other bioactive molecules and you don't know what they're doing. Whereas if you go with a synthetic THC, you're being more precise in terms of what you're going for. So this would be the preferred route for that. The other thing, too, is that many of these drugs have disparate efficacies relative to anti-nausea and anti-emesis. So a drug may be effective in terms of knocking down or attenuating vomiting, but doesn't do as well of a job attenuating nausea. So not all of these drugs are equal in that regard. So some of the evidence suggests that the synthetic THCs may be a little more effective in the nausea side of things. We know, as we've talked earlier, nausea and vomiting are two different mechanisms. The nausea is a higher brain function. Many brain centers are involved. The mechanism not well worked out. So again, it's a little ambiguous in terms of having or trying to find, the magic bullet that's going to knock both out. So the THC or the synthetic THC may be helpful on that. Also, typically, particularly with the synthetic THCs, that would not be the only drug that you would want to give the patient. So you'll pair these up. And so this type of drug here, we would call that adjunctive therapy. In other words, it would be given in combination with some of these other drugs that we talked about earlier. The last category is going to be benzodiazepines. Benzodiazepines are anxiolytics, which means they're anti-anxiety drugs. And you know the common names, Valium, Ativan, and Xanax. The way benzodiazepines work is that they are considered a GABA agonist. So GABA is a neurotransmitter. It is an inhibitory neurotransmitter. So what that means is when it is being released in the central nervous system, it's kind of a brake pedal that slows down or stops certain neurological activities. In fact, GABA is the most common neurotransmitter in the central nervous system. So we say that benzodiazepines are a GABA agonist, which of course is the opposite of antagonist. An agonist is going to mimic what the normal drug would do, or the normal molecule would do. But this is kind of a special category, because benzodiazepines in and of themselves is not going to cause a biological effect on the GABA receptor. And let me say something about the GABA receptor. The mechanism by which the brake pedal works, because again we said it was an inhibitory neurotransmitter, is that the GABA is also a chloride ion channel. So when it is normally closed, so when GABA binds to it, the presence of GABA on the receptor opens that channel up and allows chloride to go into the neuron. Well, chloride is a charged particle. It has a -1 valence. So when you're moving chloride from the outside of the neuron to the inside of the neuron, you're moving charge. You're moving negative charge from the outside to the inside, making the inside more negative than it normally would be. So we would call that hyperpolarization. And if a cell membrane of a neuron is hyperpolarized, that means it's harder to have an action potential. It's harder to do anything. So that's the mechanism by which GABA is an inhibitory neurotransmitter, is that it quiets down the neuron because it makes it hyperpolarized. As I said, the benzodiazepine in and of itself won't open that chloride channel up. But the reason that the benzodiazepine is considered an agonist is because it potentiates the activity of GABA. So when GABA binds to the GABA receptor, if a benzodiazepine is bound to it at the same time, that chloride channel is going to remain open longer, allowing more chloride to go into the neuron, therefore further hyperpolarizing that neuron, making it difficult to have an action potential. The mechanism by which benzodiazepines help with nausea and vomiting is not totally clear. Last time when we talked about all the various receptors in the vomit center, the central trigger zone, I don't think I mentioned GABA. I did not mention all the neurotransmitters and receptors involved, just the major ones. But there are GABA receptors in those areas, and the benzodiazepines interact with them to help tap down or to attenuate nausea and vomiting. Like the cannabinoids, the benzodiazepines would not be something that you would use in and of themselves, but you would also use that as an adjunctive type of therapy. This can be particularly helpful when we are dealing with anticipatory nausea, vomiting associated with chemotherapy. And it may be because of its anxiolytic activity, but again, the nausea and vomiting can be an emotional thing, and we saw earlier, someone going in for chemotherapy can become nauseated and start to vomit just by being in the same room where they get the chemotherapy. Again, classic Pavlovian type of conditioning here. So in that regard, some of these anxiolytics can actually be helpful in tapping down that anticipatory nausea and vomiting associated with chemotherapy. I want to end on a different note. I've gone through 7 basic categories for anti-nausea, anti-vomiting drugs. I want to end on the opposite. An emetic, a drug that actually causes vomiting and nausea. One of the drugs I want to talk about, and the reason I want to talk about it because you can buy it in any drugstore, Ipecac syrup. You can get it at Walgreens. If you buy Ipecac syrup and you drink some of the Ipecac syrup, you're going to vomit. It's been around for a long time. It is an alkaloid, and as you recall from earlier chemistry courses, an alkaloid is an organic compound, a series of carbon atoms with a nitrogen group on it. They occur naturally in nature. Alkaloids are everywhere. Morphine is an alkaloid, comes from poppy plant. Atropine is an alkaloid. Strychnine is an alkaloid. So lots of alkaloids out there in the environment. In fact, the word alkaloid comes from the word ashes of plants. The way Ipecac syrup works is that it irritates the gut. And again, as we saw earlier, if you're irritating the GI tract, you're going to have cells releasing serotonin, binding to the 5-HT3, vagus nerve, sensory component, talks to the vomit center, etc. You know what happens. The Ipecac also works on the central trigger zone. The mechanism there is not particularly worked out, but we know it can have effect as well there. So I have 3 things here: Ipecac syrup, gastric lavage, and activated charcoal. Well, what do all 3 of those have in common? And this is more of an historical point. And that is, what do you do when someone ingests a poison or maybe an oral overdose of drugs? Well, old school would be that you would just, if they took a bunch of pills or had some poison in them through mouth, you would make them vomit. So you would give them an emetic and they would throw the poison up. And for years, that's the thinking. Another approach would be to give a gastric lavage, or the street term for that is stomach pump. And you've all seen the movies, took a bunch of drugs, went to the emergency room, they pumped my stomach. And the third is activated charcoal. Activated charcoal is interesting. Charcoal has this really curious attribute in that molecules stick to its surface. You could say, in a sense, the surface of the surface of charcoal is sticky. So it binds to a lot of different kinds of molecules. So we would say that charcoal adsorbs things. Adsorbs, as opposed to absorbs. So those are 2 different things. Please look it up if you don't know the difference. Adsorb is what charcoal does. Activated charcoal is basically charcoal that has undergone a series of chemical processes. And the idea is that you want to maximize the surface area to volume ratio. Because if the way charcoal adsorbs molecules, it's a function of how much surface area it has. You want the most surface area. So activating the charcoal means you've maximized the surface area of the charcoal so it does a better job of adsorbing what's around it. And of course the thinking is, if you give somebody charcoal, it's going to adsorb the toxins. Of course the question would be, how does the charcoal know what the toxins are? And the answer is it doesn't. It just adsorbs everything, and hopefully the toxins would be a part of that. Okay. When someone comes to the emergency room and they have ingested a poison, none of these really work. The reason they don't work is because by the time the person has made it to the emergency room, whatever they ingested has already made its way to the small bowel, the small intestine. So having somebody remove stomach contents isn't going to do any good if it's already in the small bowel. When you ingest something into your stomach, it doesn't stay in your stomach that long. So within an hour, most of it's already in the small bowel. So doing a gastric lavage or charcoal or causing them to throw up isn't going to help you out at all. That's why none of these are really ever used in an emergency room. There's no reason to. There are other things to also be concerned about. Anytime you're causing somebody to vomit, particularly if they're physiologically impaired, you run the risk of them aspirating the vomit. In other words, they're inhaling it into their lungs. And of course, if you aspirate vomit, you've got a whole nother set of problems. This is another risk factor for activated charcoal. Activated charcoal can irritate the gut. So if you give somebody activated charcoal thinking you're going to adsorb toxins, and they irritate the GI and they end up vomiting the activated charcoal, the last thing you want is for them to aspirate activated charcoal into their lungs. That's a very bad outcome, so you just would never do it. Another point on the activated charcoal thing, the science that shows how effective the activated charcoal actually is in adsorbing toxins and such is pretty thin. There's not a lot of research out there that makes that shows in a definitive way that it's really that effective. So there are just multiple reasons never to use activated charcoal. And again, gastric lavage is usually too late. The emetics or ipecac syrup, again, aspiration, again, too late. So again, I just want to bring this up to you because this is more of a historical thing. So you may ask, well, if you can't do any of these and somebody comes in the emergency room and they have overdosed on pills or have ingested a poison, well, what do you do? Well, it depends. If there's an antidote to the poison, of course, you give them the antidote. Short of that, your role as a healthcare worker is supportive care. You're basically going to watch them, observe them for whatever time period that drug is going to dictate, and it has to do with the half-life of the drug or the poison. But you're going to be supportive care, trying to address whatever symptoms are occurring because of the poison or the excess pills. That's basically the best thing that you can do for the patient and hopefully have a good outcome. All right, well, that ends my series on nausea and vomiting. I hope you have found some of this interesting, and thank you very much for listening.